Welcome to The Cut, a series where I'm talking to experts about how small changes can have a big impact on patient outcomes after surgery. Hi Jane, thanks for joining me today. How are you?
I'm fine, Kylie. It's lovely to be able to see you out of
in person.
Exactly.
I know.
Yes.
It's great to have you part of The Cut, this series that's looking at generating awareness and advocacy for surgical wound management. And I'm really interested in hearing your story about some of the challenges that you find on the road in community care in Denmark. So tell me a little bit about some of the challenges that you face, particularly around surgical wound management.
I think one of the key challenges, if we start right from the point where the patient comes home having had a surgical wound, is that many community nurses are unaware of what is abnormal. Because they see so many surgical wounds which are still producing some exudate 5 days later, a week later, 2 weeks later, we've done some research and can see audits, we can see there's around about 40% of our surgical wounds, closed incisions, are actually in fact still producing exudate 1 week, 2 weeks later. And because that's so normal, it's considered to be normal. So the nurses don't stop up and think, do I need to do something different? They continue with the same basic dressing that the patients come home with from hospital. And then 8 weeks later, the patient's still got a wound. Maybe most of it's healed up, but there's still a defect, as I call it, a dehiscence. Maybe just a small one, but it's still requiring input from the community services. So I think one of the key challenges is lack of awareness or not being educated. No, it's not really not being educated, but it's a lack of awareness of what should be normal and what is not normal with an incisional wound. I think another challenge perhaps is very much focus on surgical site infections. But quite often, with a wound that's not healing, there isn't any sign of infection. And it's not necessarily infection that is the cause of a defect, a small dehiscence, or the fact that there's still exudate coming. It could be a hematoma, it could be seroma, other things. But because we hear all the time about surgical site incision,
We do.
Surgical site infection, that's what the focus is on. And when the nurses out in the community, you don't see sign of infection, so they think, it's just going to heal up anyway, eventually. Another challenge is we've experienced recently is with wounds where the information from on the discharge letter, it says the surgical site looks fine, it's dry, no redness, no sign of infection, which of course we wouldn't expect so soon after the operation. But the key thing is that the description is that the wound is dry. So we think, fine, we can just put a normal silicone dressing on or any other type of dry dressing, which will just cover the wound. But actually, sometimes it's the doctor who's told the nurse the wound looks fine, but hasn't seen that there is actually exudate discharge on the dressing that's been taken off. So our nurses, the community, interpret that the wound's fine, we don't need to do anything until we take the stitches out in 14 days. And it could be that there's a healthcare assistant is the one who's going in to help with the patient with our other activities and is expected to check the wound and doesn't think there's a problem, whereas actually there is a problem. So there's lots of interesting things.
There are a few
for
conundrums
us when patients
there.
come home. Yeah,
Definitely a few conundrums.
Yep.
And it sounds like, well, it's definitely around education to some extent. But one thing you mentioned was this whole idea of picking it up early on and early detection. And I like what you said about the wound breakdown may not be related to infection. And we're singing from the same hymn sheet there, aren't we?
I think we are.
We are. Because we get so hooked up or hung up on surgical site infection. What do you think it's going to take to have that paradigm shift around, is it really an infection or is it just a normal inflammatory response?
I think it's a challenge for us to have some concrete evidence on what the problem is. Because when patients are discharged from the hospital, they're often, in Danish, udskrivet, they're not expected to have contact with the hospital again. So those patients are now out in the community under their own general practitioner or the community nurses. And we don't have easy access to wound swab culturing checks and things. And if there isn't a specific sign of infection, then they're not going to be checked for bacteria. And I think in order for us to come away from that every time there's a problem and a dehiscence that there's infection, we're going to need to take some wound swabs from these wounds to demonstrate that actually, no, this problem isn't related to infection, it's to something else. And there can be so many things it can be related to. It can be the suture material that's being used. It could be the way the wound has been sutured together, that the edges haven't come together. It could easily be the dressing choices that have been chosen. There could be something with the patient in their diet. There could be so many different aspects. But we know that's a challenge with wound care anyway, to have evidence of what is or what is not a problem. So.
It's almost you need to do some sleuthing,
Yeah.
investigate, go for a deep dive and see what's happening with that wound, what the patient's doing at home.
Indeed, yeah.
That
And
could be.
maybe we could just collect some data out in the community. Basic data, how many patients are there in fact? What does the wound look like? What are some of the, are there not some risk factors for patients with the multiple illnesses that they have that are a risk factor? But we need data.
It's
So we
true.
can't just sit back and say, no, I'll go out and change the dressing. We need some data coming in, a bit like we have done it in August, where we have looked at, for example, all of the surgical wounds over a month, and what percent we can see there's 40% that have a problem. But why is there a problem? What is it? We need some more in-depth data.
Indeed, and that seems to be a general consensus as well. We just don't have enough data around the burden of this type of wound, more particularly in the community nursing setting.
Yeah.
We know what's happening in the acute care setting because we've got systems designed to collect that information.
Yeah. But the challenge today is that patients come home after operation so much quicker than they did for 10 years ago, for example. So that these issues, they're picked up in the community 5 to 10 days, 30 days after discharge. So,
So much work to be done, Jane, but it sounds great that you're collecting that information and you're publishing.
Yeah.
Which
Every
is
now and again.
fantastic.
Yes.
Fantastic. So tell me, for the young nurses that are watching that may be in the community nursing setting, some hot tips for young players.
Yeah.
Tell me.
I think for me, wound care is exciting and always has been. And I know my colleagues say that I'm a complete wound nerd. But I think...
That's a thing.
Yeah, that's a thing.
That's a thing.
Absolutely, absolutely. Because when it goes well, we can see that our input as nurses has made a difference. That's what is so exciting. The patient has a better life because their wound has healed up quicker. So I think be enthusiastic about wound care. Again, in the community in Denmark, wound care is the #2 activity for community nursing after things related to medicine. So it's a huge deal of community nurses' work. And I think a new nurse needs to come up to speed as fast as possible and not just come out and change the dressing, but be inquisitive about what does the wound look like? Why have we chosen this dressing? And maybe challenge your colleagues about, I've just heard about something different. Could we not look at using that instead? Gain knowledge from where you can. If you've got a wound specialist nurse in your organisation, take contact to them, because we would love to share our knowledge with others.
Stories.
And stories, exactly, and reasons why. So I think a key thing as a new nurse working in the community, particularly with wound care, is to ask why all the time. Is what I'm doing the best that's possible for the patient? Are we doing it just because it's what we always do? Well, actually, we've got new knowledge, new products, maybe something that fits with this patient better than what we've been using before.
Some great tips. And I'm sure that young nurses, if they sort of get the bug of your passion and enthusiasm, Jane, then the future's secured.
Hopefully.
For our patients, that inquisitive mind, not being afraid to challenge your colleagues and have that passion to try something different and new. Jane, always a pleasure.
Thank you very much, Kylie.
Thank you so much for joining me today.
Thank you for inviting me. It's brilliant.
You're welcome. Thank you.
Yes.